Good day. My name is Niall Ferguson. I'm head of critical care at the University Health Network and Sinai Health in Toronto and professor in the Interdepartmental Division of Critical Care Medicine at the University of Toronto. For the next 12 minutes, we're going to talk about ECMO or ECOR for lung protection. These are my disclosures, which may be relevant to this talk. Let's start off talking about ECOR, extracorporeal CO2 removal. This has been touted to us as a simpler and more gentle, safer form of extracorporeal life support, where you see it's been compared to or labeled as respiratory dialysis, and you see in advertising pictures pulled from a manufacturer's website. Patients are not even intubated, they're smiling and don't even look that sick. The general setup for ECOR is similar to full ECMO. In this illustration, we have a single dual lumen cannula, which sucks blood out through a centripetal pump, pumps it through a membrane oxygenator, and returns it with oxygen added and CO2 removed, more or less in the same spot that it was taken. It's also possible to do this using a pumpless arterial venous setup, but that's less commonly used nowadays. Why would we want to do this? Well, one idea is that in some patients, we still have significant ongoing ventilator-induced lung injury despite lung protective ventilation. In this case series, investigators from Marco Ranieri's group religiously applied the ARDS-NET protocol and showed that when they did CT scans, in some patients, everything looks fine. But in other patients, those with the most atelectasis and the smallest baby lung, even 6 mils per kilogram resulted in significant overstretching in the non-dependent regions, as outlined in these red schema here. And similarly, we have data showing really there's what appears to be a linear relationship between day one plateau pressure and mortality that does not have a threshold, at least identified from the ARMA trial. And the idea with ECOR is that we may be able to move from here down to here and use ultra-protective ventilatory strategy and avoid the respiratory acidosis that would otherwise come with this. We know that driving pressure is strongly associated with outcome in ARDS. And the idea is with ECLS, whether it's ECMO or ECOR, we could drive down the driving pressure, improving mortality potentially. Again, this is not a new idea. This paper from Luciano Gattinoni in JAMA in 1986 is a case series saying we may be able to use low frequency and lower positive pressure ventilation by using extracorporeal CO2 removal. ECOR is a form of extracorporeal life support, your VV ECOR. What separates out VV ECMO from VV ECOR, though, is a little bit of a gray area. It's mostly about flow rate rather than about the technicalities of the device. Current indications for ECOR based on evidence are, it's a very short list, nothing. Potential indications, there are several, one of which is facilitating ultra-lung protective ventilation in ARDS or acute respiratory failure. There's a nice review and overview of current knowledge and research questions, clinical potential for the future in the Lancet Respiratory Meds a couple of years ago. And again, they point out at the current time, there's insufficient evidence to recommend the routine use of ECOR for acute hypoxemic respiratory failure. It is being investigated though. This is a pre-pilot study of 15 patients showing that these investigators were able to get the tidal volume down to 4 mils per kilogram with no significant change in the CO2. They did achieve a significant reduction in driving pressure, but this, at least in this small case series, came at the cost of significant hypoxemia in about a third of the patients. The larger supernova pilot study of about 100 patients published in intensive care medicine last year showed that across a range of devices, investigators were on average able to keep the PCO2 around baseline with no major fluctuation in the PF ratio. And they did drop the tidal volume down to 4 mils per kilogram within 8 hours and kept it there for 24 hours. And this was accompanied by a drop in driving pressure on average of about 3 or 4 centimeters of water. There were differences, however, in this population according to how much the driving pressure dropped. And that was related both to the type of device that was used, whether it was a high efficiency device or a low efficiency device. And it also depended on the patient characteristics. And the most important characteristics were the baseline alveolar dead space fraction and the respiratory system compliance. So in the darker orange up here, patients who had a high dead space fraction and a poor compliance had large reductions as high as 8 or 9 centimeters of water in driving pressure when they went on ECCO2R with a high efficiency device. With a lower efficiency device, that same patient only had their driving pressure drop by 5 or 6. And you can see here, there's a significant separation between high efficiency and low efficiency devices in the proportion who were able to achieve the targeted primary endpoint, i.e. keep the tidal volume, drop the tidal volume while keeping the CO2 the same. And while it didn't matter what the dead space fraction was, with a high efficiency device, you could achieve this in every patient, whereas the low efficiency devices really were only able to do this satisfactorily in patients who had pretty low dead space fractions. Now, there's several trials ongoing looking at ECCO2R, one of which has just stopped recently, but results have not yet been made available, is the REST trial from the UK. And so this will undoubtedly add to our knowledge base about the role of ECCO2R in acute respiratory failure. But this was using a relatively lower efficiency device, so it may not be the final answer to the whole story. Because we've been sold a bit of a dream about ECCO2R. It's smaller, safer, easier, more feasible in the whole lung dialysis concept. As written in Lancet Respiratory Medicine here earlier in the year, extracorporeal CO2 removal is a technique that can be performed in more ICUs due to the much more lower level of complexity than is required for ECMO. Now, that might be true for a low efficiency device. And it may also be true for things like acute exacerbations of COPD or even chronic hypercapnic respiratory failure. But when we're talking about using higher efficiency devices to remove large amounts of CO2 in patients with severe respiratory failure, at the current time, high ECCO2R involves essentially using a full ECMO circuit, just at lower flows, potentially with slightly smaller cannula. And so why is this safer? You might actually need it might even be less safe because you may need to use more anticoagulation if the flow is lower and you have to deal with more issues with hypoxemia. There may be a safety issue if you're only using the circuit to facilitate ventilation. If there's a complete circuit failure, then that might not be a disastrous outcome as it would be in regular ECMO. But it also means that the intervention is by definition less effective. So I wonder also about using ECMO for CO2 removal. This is the Aeolia study that most people will be familiar with, comparing VV ECMO to standard lung protective ventilation and prone positioning to improve mortality. Remember, patients got into this trial for one of 3 reasons: extremely severe hypoxemia for a short time, severe hypoxemia for 6 hours or more, or refractory respiratory acidosis for at least 6 hours. Most patients, almost everybody in the ECMO arm got ECMO, and there was some degree of crossover. And the outcomes favored the ECMO group, but didn't quite reach statistical significance. But this was a trial of lung protective ventilation versus not, where the ECMO group had a significantly lower tidal volume and a significantly lower driving pressure than the standard care group. When we look at subgroup analysis here, we'll just blow up one that's borderline significant, and that's baseline oxygenation. In contrast to what many people might have thought, it wasn't the people who were dying of hypoxemia that benefited most from ECMO. In fact, the outcomes are almost the same in those patients. It was those with less severe hypoxemia where a large difference in outcome was seen favoring the ECMO group. And if we look at this in a slightly different way, according to the criteria of enrollment, the largest benefit was not in the patients who enrolled for hypoxemia, but those who were enrolled because of respiratory acidosis, despite optimal lung protective ventilation, with a very large absolute risk reduction outlined here. So Eddie Fan and I are exploring this further, and we're funded by a CHR to start with a feasibility pilot, looking at patients with moderate to severe ARDS who don't meet an EOLAR criteria, because we think those patients already should get ECMO, but who have a high driving pressure despite a relatively low tidal volume. And we're going to randomize those patients to ultraprotective ventilation through ECLS with a dual cannula setup and essentially ECMO light, and compare that with extremely lung protective ventilation compared to the standard ARDS network ARMA trial with prone positioning. At the current time, ECCO2R and ECMO for patients outside the EOLAR inclusion criteria remain investigational. At the current time, our best path forward in these hypoxemic ARDS patients is to follow an algorithm something like this, where if the PF ratio is less than 150, prone positioning, think about neuromuscular blockade and high PEEP, and then put on ECMO if they meet EOLAR criteria. Further answers to come in the future. With that, I will stop there and thank you very much for your attention.